All right, I think that we're at 1 o'clock, so let's go ahead and get started. Can you hear me okay? Can someone confirm, please?
I can hear you.
Thank you very much. My name is Casey White, and I'm the project manager of the Simons Simplex Collection working for the Simons Foundation. First of all, I'd just like to welcome everybody to our very first SSC at EN webinar, where we invite researchers to share information with the families who have helped make the research possible. We're also happy that you guys are here with us today. Just a few quick comments about how the webinar works in case you haven't ever attended a webinar before. What you're going to do is watch the presentation right on your computer screen, and you should already see an introduction slide there. And you will hear it through your phone. So in order to minimize disruptions, because we did invite so many people to attend, what we're going to be doing is muting the lines of everyone except for the presenters today. This is just to minimize our disruptions, so please don't think we're ignoring you if you're talking. It's just that no one but the presenters can actually be heard. If you have questions you'd like to ask Dr. Kanne, your invitation included an email address where you can send your questions. We've already received some, which is great, and we'll be going through and selecting some of those to be asked at the end of Dr. Kanne's presentation. So please do send an email if you have questions you'd like to ask. Finally, we are recording this webinar, and we'll post the video on the SSC at EN website as soon as possible. The SSC at EN team will send you a link so you can watch it again or share it with friends and family or whatever you'd like to do. So speaking of the SSC at EN team, they would like to welcome you as well. I'm sure many of you have spoken with or emailed or at least seen the name of SSC at EN's coordinator, Tara Zandi. She and the SSC at EN team have been working tirelessly on the SSC at EN community. I'm so happy that they've also joined us today, and I'd like to give Tara a quick moment to welcome you as well. Tara?
Hi, can you hear me?
Yep.
Okay. So, hi, this is Tara Zandi. Like Casey said, I'm the SSC at EN Research Coordinator. So here at the Interactive Autism Network, we have been working to create an autism research home for Simons Simplex families. And we hope to share SSC-related findings with families just as we are with this webinar, and just to facilitate your involvement in future studies and online surveys. So far, more than 1,000 families, SSC families, have joined SSC at EN project, and we hope to welcome more over the coming months. And I look forward to working with you. So I'm here to you know, if you have any question about SSC at EN, please feel free to contact me via email or phone call. And so now I will be presenting our Dr. Stephen Kanne of the Baylor College of Medicine, who used information provided by Simons Simplex Collection families to better understand meltdowns and aggressive behaviors in children with autism spectrum disorder. Dr. Kanne?
Yeah, can you guys hear me okay?
Yes, we can hear you.
Okay, good, because I wanted to make sure I was unmuted. Well, hi, everybody. Thanks for showing up. It looks like we have a pretty good response here. I also want to give a shout out to Micah Mazurek, Dr. Mazurek, who I worked with when I was in Missouri, who was the co-author on this particular project. She couldn't be here for family reasons, but she wanted to give her regards as well. Let me see. Yeah. So this question, we came about it kind of not directly, but we were involved in some other stuff that led us to this particular research question. Of course, our specific question is how common is aggression in children with ASD? What are the risk factors and what does this mean for intervention? That's kind of what we're going to go through today and kind of what our research was really focusing on. I always like to start with this slide here because you know, we all understand autism, that there are these core symptoms that really drive the diagnosis, the deficits in socialization, problems with reacting to their environment in different ways, whether it be repetitive behaviors or restricted areas of interest, and these delays or deficits in their ability to communicate effectively. But autism is much more than that, as you guys all know. We often have all these other things that float around the core symptoms. Oftentimes, kids with autism experience ADHD, cognitive problems, seizure disorders, sleep problems, GI problems, problems with just, you know, adaptive skills like making your bread and brushing your teeth, sensory problems, mood problems. But one thing that people haven't talked a whole lot about is aggression, and that was our question too, is like, you know, we don't really consider it a core symptom of autism, but we know a lot of kids with autism experience aggression. So what we want to do is obviously, this is a huge question when we work clinically with parents and with families, that if a child is experiencing aggression, this is a huge thing. And it comes up as a problem that they definitely need to get their hands around and be able to treat or somehow fix. And like I said, it wasn't like we were just sitting around saying, okay, what do we want to study? Let's study aggression. It actually came about because we were developing at the time a new intervention for adolescents with autism, where aggression was a big piece of it. So where whatever behaviors they have, the problematic, challenging behaviors, were a big piece of the puzzle that really made it difficult to work with these patients, for the families, that is, and for the clinician. So we were trying to develop a whole new intervention. And to do so, though, we wanted to back up and say, okay, what is the literature? What do people know about aggression and autism? And we were surprised at the time that there really wasn't a whole heck of a lot out there. So what I want to do with you now is just kind of back up and let you know what we found in terms of kind of past research that people have looked at. Well, one place to start is in the general population. What have people looked at with, when children are aggressive, what does this mean? Not whether or not they have autism, but just in the general population. Not surprisingly, it affects so many things. It affects that child's ability to function appropriately in the community, in the family environment itself. Once you add aggression into the mix, you have a lot more stress in the family. And of course, the individuals themselves, the ones that actually aggress, there's outcomes for them as well, which I'll talk about in a few minutes in terms of what this means for them. But part of that is what you see on the next part of that slide is, if you are an individual that aggresses in the general population, what they found is you have a much greater chance of having problematic behaviors when you're older, including being diagnosed with and experiencing antisocial behaviors, conduct problems, substance use, mood disorders. So obviously, it just doesn't have an effect on the people around you. It actually also has an effect on the individual themselves. So what we then looked at is, okay, what in children without ASD, so without autism, what predicts, what increases the risk for certain kids to show aggression versus other kids? The literature has shown, many studies that when a child has a lower IQ, if a child has early delays in their language, if there's a low family income, so the family that doesn't make as much money, a lower SES, the higher the parental income, the less chance there is of aggression. Sometimes early childbearing, the different factors associated with that can have an effect and be a risk factor for aggression. They have found that certain parenting styles actually increase the risk for a child to be aggressive, like harsh parenting. And as is often true, being a guy doesn't help. So being male actually makes you have a higher risk for aggressing than a female. So one of our questions was, okay, that's what it's like in the general population. There's been tons of research which show this, that these are the risk factors. What we want to know is it the same in autism? Are these risk factors, first of all, how many kids with autism in general show aggression? And then what are the predictors of it? And if you talk to all the families out there, which you guys are a part of, obviously, there might be something that's, if you know a child who has autism and is having aggression, there might be something that's setting that particular child off. You might have identified it. Sometimes you don't know what that thing is. And that's kind of what we want to get a handle on, is how many kids in general with autism show aggression and what's really driving that aggression. The next step is saying, okay, maybe not autism, but in other individuals who have other things going on, whether it be developmental delay, intellectual disabilities, is there a difference then in terms of what happens to those kids who show aggression? And what we know is obviously it's already stressful to have a child who has any type of special needs, period, for a family. Research shows that. But then if they aggress, this is just true of just having an intellectual disability. Having aggression as well is one of the biggest predictors of crisis intervention, which is a big deal for a family, admission to a residential facility. So families just can't handle the kids. The older they get, the bigger they get with intellectual disabilities. If they start showing aggression, families just can't handle them at home, so they have to have them admitted to a residential facility. Use of medication, some psychotropic medication that kind of tones the child down, or the adolescent down, so they don't aggress. And in all, I think the most heartening or disheartening part of it is it is a predictor of individuals with intellectual disabilities of a poor quality of life. for all the reasons above that. What they found is kids with intellectual disabilities that also show aggression have a poorer quality of life and report that. The next part of that slide is actually, I think, more important to the families, is that of all, this is in intellectual disabilities, above all other factors that we ask families about in terms of taking care of a child with an intellectual disability, the strongest predictor of parental stress was aggression. You know, and that's kind of like one of those no-duh things, because, like, you know, if you've ever been in a situation where you're in a house and a child starts having aggressive behaviors, or if you're in a Walmart and a child starts having aggressive behaviors, that changes everything. I mean, the amount of stress, the amount of just the atmosphere changes because of the aggressive behavior. So it's no surprise that they found that. So what are the prevalence rates in general in intellectual disability, and if we add autism to the picture? Research shows that about 7% of the individuals with intellectual disabilities actually show aggression. If they have autism and an intellectual disability, those rates anywhere from double to quadruple. So some of the studies show anywhere between 50 and 30% that if a child has both intellectual disability and autism, they will have aggression. Problem is, there's been no large-scale studies. Most of the studies I talked about right there, it really, they vary so much in how they define aggression. You know, some might say just challenging behaviors. Some might have problematic behaviors. Someone's phone's on there where it's making some noises there. Others are, you know, there may not be as bigger studies studying as many people. So what we wanted to do is really have a study that looked at a ton of folks that had autism, that wasn't just kids who had intellectual disability or kids with severe in any aspect of autism, but the full range. Like, what does it look across the full range of autism? And this circles back then to our first slide, and this is kind of led us to these questions. How common is aggression? Can we answer that with our Simons work? What are the risk factors, and what does this mean for intervention? Okay, you guys, this is kind of a silly slide because y'all know what this is. But it's useful to remember that the folks that we got as participants in the Simons have been amazing and wonderful and come across the entire country. They really do. They represent from everywhere. And the funny thing is, even though you see a dot on part of the United States, that doesn't mean that the folks came from just that dot. I mean, there are folks that are pulled from the whole middle of the United States that went to one of those sites. So it was this great representation across the country of kids who had autism from a simplex family. And we phenotyped over 2,800 families, which is huge. And we're incredibly proud of this study because we have one of the cleanest studies ever made in terms of how we did the behavioral measures, the DNA, the repository, all that stuff. So we wanted to say, can we use this study, though, this great resource for the Simons to answer the questions that we had? So at the time, we didn't have the full 2,800 when we did the study, but we still had a huge number. So 1,380 kids is a lot. It gives you this great kind of sample size to be able to look at these questions. Those other statistics are for that sample. So the ages range from 4 to 17 years. The nice thing about that is we're able to look with that big of a sample and with that big spread of age. Did aggression change across the age? Do 4-year-olds show as much aggression as a 17-year-old? I mean, you really need a lot of numbers to be able to answer those questions, and the Simons allowed us to do that, which I'll show you. As was expected in autism, about 86% were boys. But the other part is this next part of it, which I think is really important, is that the average IQ was 84.7. So this wasn't a sample of kids with an intellectual disability. This wasn't a sample of kids that were all high functioning. You can see the range over there, the IQs of 13 to 167. I mean, it covered the entire gamut of IQ, with the average being in the low average range. So it enabled us to capture a different sample of kids that no one else has looked at in terms of research in autism, which is what we're excited about. I know this is probably kind of a boring slide for most people in terms of the measures, but those of you who are familiar with how we measure and test in autism, these are the specific measures. And by the way, all those of you who participated in Simons did these measures, so you might know what they are. But the ADI is kind of this very comprehensive interview that the clinician does with the parent about autism symptoms in the child. The ADOS is where we actually observe the child, the clinician, doing a set of tasks with them in real time and score it. The SRS, Social Responsiveness Scale, this is a questionnaire that you give to the parents to rate the behaviors of the child. The Repetitive Behavior Scale revised is, there's a part of the ADI, the first one, that kind of asks about repetitive behaviors. This is a measure that's specific, that goes in a little bit more depth about what specific repetitive behaviors a child might be demonstrating. The Vineland 2 is a measure of adaptive skills, so how do they do at home with brushing their teeth, making their beds, communicating with folks in a functional way. The next one is a basic kind of language measure, just gives a proxy for language skills. Then the CBCL, the Childhood Behavior Checklist, that kind of measures overall emotional functioning, whether it be externalizing behaviors like acting out type things, but also internalizing behaviors that the child might have, like depression, mood, withdrawal, those kind of things. And that is also a form that the parent fills out. So these are the measures that enabled us to look at these questions about aggression in this sample. But more specifically, this is a really important slide, by the way, because how we ask the question about aggression makes a difference. Meaning that, like, I can ask about aggression many different ways, and how the prevalence numbers that I'm about to give you are based on how we asked about aggression. And it's pulled from a specific question, or specific two questions on the ADI, and the two questions, 81 and 82, are, one of them deals with aggression toward a caregiver, and the other one is aggression toward a non-caregiver. We ask it in two different ways. What are they doing now? And also, in all of their lifetimes, have they ever done this? It's asked in a very broad way, meaning like, has he ever shown aggression? And then we kind of dive into a little bit more and ask more about the incident, like, did he hit, did he bite, did he draw blood, did he use an implement? And how they answer that determines the score that they get, which I'll show you next. But again, I just want to pause and say it's really important that you understand how we ask the question. It's a very broad question that allowed a very open-ended too, and scored very broadly. So, I mean, it doesn't take much to say, yeah, he was aggression. He hit, little Joey yesterday, so he would get scored for aggression. And this is how it's scored then. So you can get, each of those questions would either be scored as 0, 1, 2, or 3, where 0 was no aggression or very rare. 1 is mild aggression. You might do some threatening of other kids, like, I'm going to beat you up if you do that. Some rough play, so, as they play, they might start hitting each other a little bit. Or if someone starts teasing or bullying them, they lash out. That's a little bit of a different case, and that would get a 1. A 2, though, is definite physical aggression, meaning, yes, they've aggressed against someone. They've actually hit them, struck them with their hand, fist, whatever, or bit them, drawing blood, bruising, those kind of things. And a 3 is when it's a whole other level, when they actually use an implement, a stick, a knife, something that's violence, including the use of an implement. All right, so here's our first set of prevalence numbers. I'm talking really fast, I think. The thing I've kind of muted out that number 1, the code of 1. And I'll tell you why in a second. If you look at those are, if you look at just current caregiver, for example, let me this number right here. This means that of current caregivers, so like whoever's in the house right now, as of the last 3 months, about 43% of the kids, all these kids, by the way, again, have autism. They're all the ones that were part of the Simons project. So out of all the kids, the 1,400 kids about that we measured, how many of them were not aggressing? About 43% aren't currently aggressing towards a caregiver. But the rest of them, all these, were at some level. So currently that means that over 50% of the kids were currently engaging in some level of aggression towards a caregiver. 24% were definite physical biting, those kind of things, and almost, over 7% were using implements. Then you look at the numbers for ever, meaning has this child ever aggressed towards a caregiver? They shift a little bit, but as you can see around here, so when you add those up, you get to this number right down here, which is, they don't add up exactly because of the way that the measure collapses, but about 68% engaged in aggression toward caregivers at some point. So just pause for a minute and think about that. That means that 2/3 of the time, over 2/3 of the folks that we saw 2/3 of them engaged in some type of aggression. Some of it might have been mild, about 20% of it was just mild aggression, but a huge number aggressed towards a caregiver at some point. I kind of repeated some of the questions that people had been sending in, and this, I think, gets at one of the questions, is what we do find is that a lesser amount, the 49% down here, engage in aggression toward non-caregivers. But still almost 50% of the 1,400 kids that we saw, parents reported that they engaged in some aggression towards a non-caregiver. And if you look at this number, almost over a fourth of them had definite aggression, not just the mild type. And almost 6% had violence with implements. So the point about this is it's pretty darn prevalent. I mean, 2/3 of them against caregivers and almost 50% towards non-caregivers at some point, which are a lot larger in terms of what has been reported in the past out there. Here's a different way of just looking at that same thing in terms of breaking it down with a pie chart. So as you can see, 44% currently are not, but the greater majority, over 50%, are currently aggressing towards the caregiver. Meaning the last 3 months, they've showed some type of aggressive episode towards their caregiver. On the flip side, on the ever side, it's even more, which obviously it would be. So there's a lot more than that. Almost 2/3 of the time, there's going to be some aggression towards the caregiver. And the number that I think I find the most frightening, two of them, are this one here. 35% of the time, there's definite aggression towards the caregiver. And over 10% of the time, it's using some type of implement. And remember, these are the things that are the greatest cause of stress. And those of you who live through this yourself, you know what I'm talking about. It's like this is telling us that a great majority of the time, a lot of the parent stress has to do with when that child aggresses. So we want to ask ourselves, we have this huge sample. Because it's so large, we're able to break it down by age, meaning how does it look at different age groups? How much does the prevalence change, or does it change across age? Does the violence get worse as a child grows, or does it get less? Now, one of the caveats of this study is that it's not a longitudinal study, meaning I don't measure a kid at 4, and then measure that same kid at 6, and then measure that same kid at 17. So we can't really say that aggression for an individual gets better over time. But what we can look at is if we parse the group into sections and say, as you can see on this line here, under 6-year-olds, 6 to 8, 9 to 11-year-olds, 12 to 14-year-olds, and above that up to 17, how many of those, what is the prevalence rates for those groups that are demonstrating aggression? And you can see that it does go down. So it peaks around the ages of 6 to 8 in terms of the number of kids who demonstrate aggression. But the older the child, the less apt the parent was to report aggression in that child. So 15 and 17-year-olds have a much lower prevalence rate, according to these numbers, than a 6 to 8-year-olds do. What that might mean and how we interpret that's a whole different question. Could it be that that those kids don't have as many opportunities to aggress? Is it because they've developed coping skills or coping mechanisms to not aggress? Have they learned different things to accomplish rather than having, demonstrating aggression? But it is interesting to note that the numbers do show that as the kids get older, at least if we look at it like this, that less kids who are older show aggression than the younger kids. Which leads us to the next question. And for me, prevalence was one thing, which was interesting. But to me, the most, as a researcher, the more interesting thing was, okay, what predicts it though? Based on the, this is like, we're looking at a database in terms of what do I have in my database of all these measures that we gave the families. And my gosh, we spent, what, 2 days with the families just measuring everything we can think of. Is there something that we can get from that, from all those measurements to say, what do we have that, from our measures that can actually predict the aggression? So there's this thing called logistic regression. I kind of geek out when it comes to statistics, so I'm not going to do that to you guys. But basically, it's a technique that we use to say, when I have this list of things, a whole, basically an inventory of different things, and I put them into a funnel, which are the ones that pop out of that funnel as the strongest predictor? So, I could throw everything in there. I could throw how old they are. I could throw how much money the parents make, their education. what I want, through our statistics, I want to say, of all those things, what does my model tell me is the couple things, or more than a couple things, what are those things that are the most predictive of whether or not a child is going to show aggression or not? So we use logistic regression to do that. It's a very standard kind of predictive technique, by the way. It's not something we made up on our own. Okay, so this is what we found, and I found this very interesting. So we threw everything in there. The things that were not predictors were the parent marital status. So whether or not the parent was divorced or married did not predict aggression in the child with autism. If you remember, parental education was one of the things that predicted aggression in the general population, with lower education predicting aggression. Here made no difference. So parental education was not a predictor of aggression. If you remember in the original one, in terms of the general population, being male was a significant predictor of aggression. With autism, it was not. So being male or female did not predict aggression, meaning males didn't have a higher rate of it. Being a male didn't put you at greater risk for having aggression. If you remember the general population, IQ was one. So lower IQ kids tended to aggress more. Here, IQ was not one of the big predictors of aggression. It didn't come out as significant. So there was just as much of a tendency for a kid with a 150 IQ to aggress than a kid with a 45 IQ. Language, at least the measure that we had of language, was not a predictor, because a lot of people think, oh, you know, one of the reasons why kids act out so much, you know, is because they can't communicate. That might be true, but in terms of acting out in the form of aggression, that's not what we found. So their language skills in a basic sense, receptive language in this case, was not a predictor of aggression. And then the clinician rated ASD symptomatology. What that means is, you know, on the particular test that we had, where we could say, okay, you know, in the roughest way possible, can we have some rating of how severe the core autism symptoms were? This is what they showed us in clinic, not what the parents rated. This is what we saw. And that wasn't related to whether or not the child aggressed. Things that were, the first thing you saw on that last slide I showed you was age. So the younger the child was, the more apt they are, or it was predictive of aggression. This next one, we've been trying to wrap our heads around, and there's actually some other interesting evidence popping out. Family income was a significant predictor of aggression, but it wasn't the lower family income, it was actually higher family income. So those families that had higher income, actually, for whatever reason, their children had a higher risk of showing aggression. We're still, by the way, trying to wrap our heads around that one. Parent-reported ASD symptoms. This makes more sense to me, though, because this is, you know, this is the parents' rating on what do we see at home related to core symptoms of autism. And what we found is that the higher the parents rated core symptoms of autism, that was actually a risk factor for aggression. Those children that had more core symptoms per parent report were also those that had a higher risk for aggression. And then I think the most important one, for me at least, was the bottom one, is repetitive behaviors. So when we threw in all these different measures, one that popped out as significantly predictive of aggression is the more repetitive behaviors a child demonstrated, the more apt they were to engage in aggression. So let's dwell on that just for a minute here. This comes from that one specific measure that I was telling you about that really dives into and looks at aggression much more completely, and it's the Restricted and Repetitive Behavior Scale Revised, RBSR. I just wanted to dive into it just a little bit just so you guys can get a sense of what it means. You know, the scores, when we give that, range from 0 to 95. Higher scores mean more repetitive behaviors. They look at everything from circumscribed interest to ritualistic behavior to stereotyped language. You name it, just about every type of repetitive behavior we can think of, they have somewhere on that scale. The next point on that, for each point increase in that score, the odds of aggression increase from 1 to 1.022. That doesn't seem like a whole lot when you just read it like that, which is why I put the next thing. An increase of 32 points on that doubled the odds of an individual being aggressive, meaning that if you score a 32 and the next guy comes in with autism and scores a 64, that 64 is twice as likely to show aggression. And that's true for every increase of 32 points. And you see the ranges from 0 to 95. So the point being that there is this direct connection between these repetitive behaviors and their risk factor for showing aggression. When we dove into it even further, though, and looked at what specific repetitive behaviors are predictive of aggression. The ones that popped out are self-injurious behaviors, ritualistic behaviors, and resistance to change. The first one kind of makes sense to me, because if you're apt to injure yourself, you might be more apt to injure others or engage in aggression. The next two are kind of really interesting, though, to me. It's like what that meant is those, apart from other repetitive behaviors, circumscribed interests, those kids who engage in very ritualistic behaviors and are very resistant to change, those are the ones that predict aggression. This is one of those things that, in retrospect, that kind of makes a lot of sense, though, doesn't it? And I'll go into that when I talk about the interpretation. But and this is why we do this study, is to say, when are people most likely to show aggression? Kids with autism, I mean. Well, what this study is showing us is that one of the times that they're most likely to show aggression are when you're trying to interrupt those ritualistic behaviors, or if they are resistant to change and you're trying to make a change, that's when they're going to show the most aggression. So this is one of the first studies that actually pinpoint that as like, what, of all the factors, whether it be IQ, language, income, education, one thing above all those other things that predict whether or not your child is going to have aggression are how much they show these other types of behaviors. Just going to pull it all together then. So I think we pretty clearly showed with this study and with this comprehensive sample that aggressive behavior, at least the way we defined it, is common in children with autism. Okay, here's where I have to put one of those. As a scientist, we always say, what are the limitations of your study? What didn't we look at? I think one of the big missing parts of this study, and this is true of whenever we look at the Simons data or any research database like this, to really make this complete, I would want to go back and ask 1,400 people, 1,400 parents of kids who don't have autism, the exact same question, and say, okay, in the normal, typical, general population, how many of those kids, what's the prevalence in the way we ask this question about aggression, how many of those kids show aggression? Because let's say that it was 25% and ours was 60%. Well, that's a lot different than if they only endorsed it, 6% of the time. So that's kind of the missing component here is, yeah, we can say that it's highly prevalent, but we don't know what the comparison point is of how many parents of kids who don't have autism would actually endorse that question. Of that current sample, what we found it's not associated with was the severity of autism. I think that's important to realize. It's like you don't want to have this assumption that, wow, that kid has very severe symptoms. Oh my gosh, they're going to be much more apt to aggress. It's not true. We're not finding that at all. Kids who are high functioning, regardless of intellectual functioning, regardless of core symptoms, are just as likely to aggress. That's the measurement of their core symptoms or their IQ or their language is not what's predicting their aggression. It's these other things. Whether they're male or female. We always are more afraid of the males than the females because of our past literature that we know that males are more apt to aggress. It's not true in this sample. That's not what's driving it. And neither is whether the parents are married or divorced or how educated the parents are. We did find kids who are younger tend to have more aggression. When the parents report more core symptoms, we see more aggression. I don't even want to talk about that next one because I don't really understand it. So families with a higher family income, for some reason, we do have some theories about that I'll admit are highly speculative. That because they're that speculative, I really don't want to go into. But we're trying to get our mind around that. Why did that pop out? And if you guys have ideas, I'd love to hear them. But also, I think for me the key one was that bottom one. Was if a child shows more self-injury, more ritualistic behaviors, or is resistant to change, those are the kids that we really need to keep our eye on because they're the ones that have the highest risk of demonstrating aggressive behaviors. Which kind of leads us to the next point is, okay, that's all well and good. That's just science, though, meaning like what really matters is how can I help, clinically, how can I help kids? And that's why it's really important to demonstrate these kind of studies to say, aggression is a big deal. It's not just this thing that happens to a couple kids out there. 68% of them were reporting it. That's huge. So we need to pay attention to this. And we know that aggression is the biggest cause of stress in parents. So we can build this argument that clinicians and families should be aware of it. And it helps us make the argument that then we need to develop better and more interventions to address it. If nothing else, aggression should be assessed in every family. And if it's there, we need to deal with it. But that kind of begs the question, though, so, okay, if it is there, what do we do? All right, we got the next one. So the last part of that is we need to address and assess repetitive behaviors because that's such a strong tie to the aggression. That might be our hook. That might be our doorway into how we address aggression. Because if you don't understand where the aggression is coming from, it's really hard to treat it. But if we know for a large percentage of these kids that their aggression is tied to those factors, then we can actually focus on those and address those. In the last part of the talk now, the last couple slides. So what's out there right now? And again, you guys probably know this equally as well as I do, if not better. ABA is a big one. Any type of those, a therapy that's grounded in behavioral interventions. I've worked with some amazing people who work on teams where they work on the kids who are either self-injurious or have high levels of aggression. And it's you got to be a tough person to work on in that particular team, but they do amazing things. So the behavioral approach can make incredible changes in these kids who show aggression, because what they do is they try through their process to understand, first of all, what is the function of the behavior? Why is this child showing aggression? Why? Is it because they have a hidden injury that they're in pain they can't tell you about? Is it because of they want to so much keep on watching Thomas the Train, you're trying to stop that and they're going to lash out at you? Why are they engaging in the behavior? And that's what the ABA folks are really good at figuring out with functional behavioral assessments. What is the purpose and function of the behavior? And then knowing that, what can I do to tweak, change that, give it a better outcome, a different way of expressing themselves, how can I intervene from the behavioral perspective? Risperdal there's one of the few medications actually that has a lot of evidence behind it now is working, is Risperdal and the other atypical antipsychotics in terms of addressing these challenging behaviors. So that's actually a very good choice as well. I put that last one on there, multisystemic therapy. This was actually the technique, the style of therapy that we're working on and doing some clinical trials up in Missouri, and showing very promising pilot studies on that it's working on. What we do there is we don't actually just work with a child with aggression, we actually work on the entire system. So teachers, parents, social workers, whoever is a part of your world of autism and how you're navigating it with your particular child, we actually enter into that world with you and try to address the entire system. And what we find is that was actually lowering the child's aggression as well when we actually address the whole system. That particular therapy, in terms of its adaptation to autism, is actually in its infancy still. Questions? Okay, so this is my turn now to say, okay, I just talked for I think how long I was supposed to. And I wanted to make sure I gave some time for you guys to comment and ask questions and stuff. So am I supposed to pass off the presenter thing now to you?
You don't have to. Can you hear me, Steve? This is Casey.
I can hear you, yeah.
Okay, great. No, you don't have to. You can just hang on to it. Because what I'm going to do is start going through some of the questions that have been sent to us. And first, I'd like to start by saying thanks so much for taking the time and for your talk. It's very interesting to hear what you guys have found.
Thanks.
So I'd like to start off with some of the more, I guess, general questions where somebody was just wanting some clarification on something that you said. So I have a couple of those first. One is from Rachel, and she wants to know what is considered an implement? Is that a ball or just an item around the house, or does it have to be a weapon?
It does not have to be a weapon. So it's whenever you pick up something and hold it in your hand and then hit them with that. It's a good question about the ball. I mean, if I pick up a ball and throw it at you, is that considered an implement? In its strictest sense, it is, because, if I picked up a rock and threw it at you, that would be considered using an implement. So whenever you use something outside of your own body, it's considered an implement that you hit someone with. And it is considered a higher level of aggression because you're actually using a tool to hurt someone with.
Okay, thanks. Another one is somebody wanted to have a ritual explained a little more. They ask if it's like lining up blocks, and why would having more ritualistic behavior make their child more aggressive?
Yeah, no, it's a great question. Yeah, so that is one example of how we can think about ritualistic behaviors. So if you think about it, there's two aspects to kind of a ritualistic behavior. There's the actual ritual itself, meaning what they're engaging in that has a particular sequence about it. So most ritualistic behaviors have some type of either set sequence about them or something that has to be a certain way, and that's what makes it the ritual. So it could be as simple as, I need to line up these toys, but you've met kids who it's a repetitive behavior where they line up toys, but it's not ritualistic. meaning I can come in there and move the toys around, and they're perfectly okay with that. They'll just put it back themselves. So it's a repetitive behavior because they're interested, the function of that is just to repeat the behavior. Ritualistic is different. It means that, no, this block needs to be in this place, this block needs to be in this place, and if you move it, I'm going to get highly distressed. So there's this distress component that's associated with when you interrupt the ritual. There could be verbal rituals, meaning like, let's say that I know an episode of Angelina so well, a cartoon, that, Mommy, I'm going to say this. Now, after I say that, you have to say the next line, and then I have to say the next line, and if you don't say that, then I get upset. Or it could be just a stereotype language, like if I say this phrase, you have to reply in a certain way or I get upset. You'll notice that common theme through, to define the ritualistic behaviors. That means that there has to be usually some type of distress if whatever they're doing becomes disrupted or somehow interfered with. A little bit different, like compulsive behaviors, the next step up, where they actually feel some type of compulsion to doing something in a particular sequence. That if you interfere with it, it messes them up more. But then if you understand rituals that way, it's not that big of a leap to say, okay, I can see where they're more at risk for aggression, because they're already going to get distressed if you change something. That's the definition of a ritualized behavior. And if I don't do that, if I don't give into it, those kids are more apt to experience and show that distress by aggressing. Does that make sense?
I think it does, and so I think the follow-up then is, what advice can you give regarding, I guess, helping them through that, or regarding discipline in general? Everything that this parent does makes their child seem to spiral more out of control.
Yeah, and that's really the whole point in some ways of the talk, is to say, okay, we don't have the answer for every child in terms of this is how you need to address those behaviors. I think the first focus is on, okay, if your child's aggressing at home, why? And what we're hoping to do with this paper is to say, well, one of the reasons why, because it's not the same, they don't aggress for the same reasons as kids that don't have autism. So whether it be, let me go back to the slide here, whether it be the ritualistic behavior or the kids who have a hard time with like change, like their room is set up a certain way, they drive a certain way to school, and if you change that and they get upset, just to know that is an area that is more laden with risk for them acting out with aggression. And that's not true of the general population. That isn't the greatest risk factors for aggression. But in our population of kids with autism, it is. So the problem with trying to address specific questions on what do I do with my child with this is, oh my gosh, it depends on every single child, why they're engaging in the behavior, what that behavior is, how they're reacting to a specific behavior. And what we want to do is just focus people's attention there and say, here's the hook. This is where, if you're doing ABA, if you're doing a behavior approach, pay attention to those, because if the child's aggressing, it might not be because of X, Y, Z. It could be because you're taking a different way to work or to school today than you always did. So keep that in mind as a reason for the aggression. But it also means that from day one, we need to develop interventions and therapies that allow the kids to develop better coping skills around those types of behaviors. So if your particular child, if you're noticing they load high on repetitive behaviors, and especially those, that's like, you know what, knowing that they're going to be at greater risk for aggression and what a big deal aggression is, let's focus on that as soon as possible before it spirals out of control. Let's make sure we do some interventions to get them better coping skills when we change. And there are many different techniques behaviorally to do that. If they're already to the aggression point, then it becomes a little bit more difficult, obviously, because you have to deal with the aggression first and then also teach them the coping skills.
All right, great. We've actually had several parents inquire about changes around puberty, whether or not hormonal changes might be affecting their aggression. In a couple of cases previously, mild-mannered kids start having meltdowns. As they reach puberty, they're wondering about hormones, possible hormonal imbalances, and if the child will grow out of it.
Yeah, that's a great question. And, it's one of those things that anecdotally, when I talk to parents, I definitely subscribe to. It's like, I have a daughter now who's going through that. I'm like, oh my gosh, she's definitely more prone to those types of meltdowns. Aggression, no, though. So she has more meltdowns, but she's not aggressive. And not to project that onto every kid, out there, but it is sort of so. If you look at the data, my data showed me that it was the younger kids who actually were more prone to aggression, not the older ones. That doesn't mean that a particular individual child might not become more aggressive as they get older. But it means when I look at the averages, it's not supporting that. It's saying that, no, the kids are actually younger that haven't developed coping skills or are more ritualistic or whatever it is. They're the ones that are going to aggress more often. So the data is telling me one thing, my instincts tell me something else. And it might be that kids, we know for a fact in autism, there's lots of studies that show that adolescents, for example, are much more prone to mood disorders, anxiety, depression, those things as they enter adolescence in autism. That's a big risk factor. Is that associated with the hormonal change? Probably. That's probably a piece of it, I would imagine. But that doesn't mean just because they're having either more emotional reactivity, more meltdowns, that's not the same as saying they have more aggression. The aggressive piece is another step. It's saying, okay, when I have a meltdown, I'm going to lash out and hit people around me. It's a different animal entirely. So my data is really telling me that it's not supporting that. It's not saying that kids, once they go through puberty, I don't see a blip right then. The peak was much younger than that. And the kids, at least when I looked at non-longitudinally, but cross-sectionally, they don't show that. They may have more meltdowns and more emotional reactivity, but not necessarily more aggression.
Okay. I've also just gotten a new question that asks whether or not the aggression may actually be sort of a sensory experience because of an adrenaline rush, and if there's any sort of data that might support that.
Sensory experience because of the adrenaline rush. That's an interesting question because I always have difficulty answering the sensory questions. And the only reason why is I'm not inside their heads, and we don't have any way of getting inside their head. Like, what are you experiencing internally that's causing you to have the aggression? And the problem with the sensory explanation in general is it's really hard to measure. It's like, well, how do I measure if a child, from my perspective, had a sensory experience? In many different disorders, you can kind of repackage as a sensory disorder. ADHD is a disorder of sensory seeking, for example. We know for a fact, that kids with autism are more prone to experiencing and having more sensory difficulties and aversions and seeking out. The sensory, it's a really good question because we didn't have a particular measure in our Simons battery that said how many sensory issues is your child having. If we did, then we could have related those too and said, okay, our sensory issues, our kids who are more prone are more sensory aversive, for example, are they more prone to aggression? So when they encounter whatever they're sensory averse to, are they more prone to act out with aggression? That's a good question. We don't have that data in this data set, but that'd be an interesting follow-up.
Mm-hmm. I have another question about whether or not violence against animals is sort of in the same category, or if that's a different sort of thing. We've talked a lot about violence against people, caregivers, and others, but if it may also apply to animals.
Yeah, in the general population, you have kids who have aggression tend to also eventually get a diagnosis, a lot of them, of conduct disorder and an antisocial disorder. And antisocial disorder does include cruelty and other things. They're more prone to cruelty to other animals and stuff. Again, that's not something, we didn't ask about that in this sample. So we didn't, nowhere did we ask, does your child also injure animals or more prone to it? So I can't say from a scientific standpoint that there is a difference between it. Responding anecdotally from the parents I talk to, kids with autism, I don't hear that they have any more or less cruelty to animals than other populations of kids that I've seen. They oftentimes react very well to animals and are, even with the horse therapy and the helping dogs, and they can respond very, very nicely to them, as well as some kids who just don't get that it is an animal, it's not another doll that I can just, try to yank on and pull. But a lot of kids do that too. So, scientifically, I really can't answer that because we didn't ask that as one of our questions. It would be interesting. I don't have any knowledge of how many of these kids that aggress go on to have a diagnosis of conduct disorder and antisocial personality disorder. My suspicion is not many because we're accounting for the aggression under the context of autism and not under a different type of personality disorder. I don't know if that was helpful.
No, I think that addressed the question, certainly. Okay, so here's one from Edith. It says, if one sees the emergence of a new ritual, would the way to handle this be to identify it quickly and start working on it before it gets any worse? I guess this is sort of getting into interventions and how that's going to deal with a child.
Yeah, and so part of it is again, if you put your behavioral hat on, the question becomes, what is the function of that behavior? So just so you know, so if a child starts engaging in a ritualized behavior or whatever, then you just know in the back of your head that, okay, this is one of those things, which again makes it's kind of no doubt. It's like when I try to change it, they get upset. Those kids that get upset are probably more prone to aggression. So just know that this is kind of an area that I got to approach carefully, because I know I'm going to get some reaction, because that's what happens when you interrupt a child who's doing ritualized behavior. And with some kids, that reaction might be aggressive. So what it does mean, though, is like, what is the function of the ritualized behavior to begin with? You know, is it withdrawal? Is it escape? Are they interested in a particular subject? Why are they engaging in it? So what we often try to do is lead ritualized behaviors into more adaptive forms of behavior. So like, you know, if it's not hurting anybody, it's not that big of a deal. But if you're engaging in a ritualized behavior for this long, you're not doing these other things you could or should be doing. So you try to move them away from their ritualized behaviors by expanding that interest, or by putting time limits or boundaries on it. You know, somehow trying to say, you know, there has to be some type of parameters we put around their engagement in this. And then if you do interrupt it, I think that one of the keys is working on them behaviorally on how you react. See, the problem with aggression, it's a safety issue. I mean, if you've ever had, you know, even a 6-year-old boy try to hit you, you react to it. You cannot not react to it. And it's one of those things from a behavioral perspective that you have the danger just in the form of behavior of reinforcing the behavior, because you back off, they get a reaction out of you, you stop pressing them. So I've just learned that, hey, if I, you know, engage in aggression, I get what I want. They leave me alone, and I can keep on doing my ritualized behavior. This is why having a professional work with you to say, okay, when they do this aggression, this is how you react. You know, this is how we have to respond to this. And if we do this consistently across caregivers and across other people interacting with them, they'll learn that the aggression is not going to get them what they want, that there's a different and better way to express whatever their feelings towards stopping it.
Yeah, that makes a lot of sense. And I think this kind of leads to what can be the last question. We've had many parents in the past 10 minutes or so asking if you can elaborate on interventions and how they can best seek these out, what they should be looking for. I think you talked about this a little bit in your talk. I think they're just wondering if there's any other evidence outside of this particular study that, you know, that you can elaborate on a little bit.
Yeah, and I would return to, you know, in terms of best practice, you know, the first thing to remember that if your child's engaging in aggression, it's number one, you're not alone. Our numbers show that a lot of parents do that. If it's something that raises that point, it can be serious. So it does mean that you want to be able to make sure you have the tools equipped to be able to handle the aggressive behavior so it doesn't get worse. So the things that we always recommend, and again, there's nothing ground shaking here. I think most of the parents, you know, have heard this before, that some type of behavioral intervention is highly recommended. So if your child is starting to aggress, you want to nip it in the bud. You need to deal with it, because you have all those other outcomes. You know, they're not going to be able to be in school. They're not going to be well around friends if aggression becomes a bigger problem. So it's almost like upping the ante a bit in terms of, I need to intervene. I need to get some type of behavioral approach, is the one that we know works great. The other is the Risperdal psychotropic type of medication. So if there's a good, trusted autism expert in your area, whether it be the lead autism specialist in your area, whether it be a psychiatrist that you know knows autism and you have trust in their management of medication, those types of medications have been shown to be very useful in helping out with those types of behaviors as well. My suspicion, like many types of therapies, the combination might be even more powerful. So those would be the other therapies, like the one that we mentioned, they're just in their infancy. You're not going to find that in your area typically. ABA and medication, those are things that most parents of kids with autism are familiar with and can somehow find in their area. Now, whether it's paid for is a whole different story. You know, whether or not insurance will cover it and whether or not, that's a whole different talk, you know, like who can get what access to service. In terms of steering you in that direction, those would be the two things to pursue.
All right, well, we want to thank you very, very much for your time and for answering all of the questions, and you know, it's really appreciated. And thanks to all of the attendees for joining today.
You're more than welcome. It's great, and good luck to everybody.